So I'm going to talk to you about tolerance and autoimmunity, and I'd like to start with a story that I'm going to return to in the afternoon, but I want you to think about it. So this is a 48-year-old man who actually is probably a CIA operative. He never really told me what exactly he did, but he developed lymphoma when he was about 41, and he didn't respond to conventional therapy, and he had to undergo a bone marrow transplant. He got a bone marrow transplant. It was mismatched specifically so that he would get a graft versus lymphoma effect, okay? And he was 5 years later, he did very well. He was on acyclovir for 5 years later, and the acyclovir was stopped on October 1st, and I think it was about 2008. On October 21st, 2008, he presented to me through the Heme-Onc clinic with an acute myelopathy and question myositis. And it was zoster. So within 3 weeks of stopping acyclovir, he got zoster. And the question is, why? And I'll return to that later on. I just want you to think about that. Okay, so we're going to talk about tolerance. We're going to review what tolerance is, central versus peripheral. And we're also going to take on the concepts of active tolerance, and that is how tolerance is not just the absence of co-stimulatory signals, but it's also the pathways by which you actually suppress effector T cell activation. And we're going to use some nice case models to describe this. And then the final thing that, as part of this talk, I'm going to also touch on the clearance of apoptotic cells, which is an absolute essential thing. If you're a multicellular organism, you have to get rid of your debris otherwise and clear it away, because otherwise at 2 years old, instead of having a nice cute little toddler of about 20 pounds, you'd have a mass the size of a refrigerator. And what I want you to go back to is take a step back and remember that the whole concept of autoimmunity was posited by Paul Ehrlich in 1900, who realized that the host, to protect the host, you also had to make sure that you only could recognize the host apart from the pathogens. So how well do we do it in 2015? Well, it looks like we do a pretty good job, but if you look at the numbers, type 1 diabetes, 1 in 800, Hashimoto's thyroiditis, 1 in 200, Graves' disease, 1 in 100, vitiligo, 1 in 100, psoriasis, 1 in 50. And these are clearly associated with genetic elements, and there may be some environmental elements. My family, Hashimoto's, happens to run in our family. But it's very interesting that this is present. So obviously it's not perfect. You don't totally suppress the immune system and keep it from making mistakes. And then, of course, the ones we're much more familiar with are rheumatoid arthritis, lupus, and Sjogren's. So what about all this? How does tolerance fail? Well, in the autoimmune model, obviously what you do is you make antibodies against self-antigen, or you start reacting with self-antigen, or you start having reactivity to intracellular proteins or intracellular nucleic acids, like in lupus. Hypersensitivity, as Dr. Calabrese, is a harmless non-self-antigen. Cat dander is not a threat to us, but for some reason, some of us make very vigorous antibody responses and really can ruin our evening if somebody happens to have a cat. And then finally, there's autoinflammatory disorders, which are really not a failure of tolerance. And just like gout is not a failure of tolerance, pseudo-gout is not a failure of tolerance, familial Mediterranean fever is not a failure of tolerance. These are all diseases of the innate immune response. So these are sorts of the challenges that our host immune system has to face. And as Lenny went through, you have the acquired immune response, which is what we're really going to focus on today, right over here on this side, the T cell receptor and the B cell receptor. We're not going to focus on the innate immunity. The innate immunity is something that gets triggered to activate the adaptive immune response, but it's not the primary mediator of antigen-specific responses. This is a little bit of a repeat, and what I want to really alert you to is remember that the T cell receptor CD4 complex is sees a trimolecular complex. It engages with MHC class II or HLA-DR, DP, or DQ. It engages and sees the entire mix, and then sees whether a peptide is there that is specific or that it has some specificity for. Now, what this absolutely requires is that you have a T cell receptor that can see MHC class II and have some reactivity with it. So for example, if I took my antigen-presenting cells and tried to present tetanus toxoid to your T cells that were specific for tetanus toxoid, it is likely that would not work, because although your T cells might see the tetanus toxoid peptide, they would not see the tetanus toxoid peptide in the right context, meaning in that your specific HLA-DR molecules. So the same is true with class I peptides, with like HLA-B27 antigen presentation, except the T cell receptor is working in the context of class of CD8. So it's a CD8 positive T cell. Many different cells do this, and these T cells that do this, that get this all going, are the dendritic cells, and they often do so in response to stimulation of various danger signals. So when we say, as we focus first on the T cell receptor on a CD4 positive T cell, remember the first thing is recognition, that is, and what you do not want to have is have T cell receptor that reacts with self-antigen. That's bad, right? You don't want that. So we have a thymus for about 13 or 14 years of our life, and that's going to be very much a part of how we get rid of these T cells. A T cell that sees the right peptide in the context of class II, but doesn't get a co-stimulatory signal, is anergized. It's either deleted or anergized. If in contrast, your antigen-presenting cell engages CD28, so the HLA B71 or B72, CD80 or 86 on the antigen-presenting cell engages CD28, you get no activation. It's not relevant. So you really need both signals linked in space and linked in time. So B-cell tolerance is a little bit different, and I'm actually going to beat up on B-cell tolerance in the afternoon, because I'm going to tell you that in some ways it doesn't really exist. But what I'd like to remind you is that for the beginning parts of life, when we generate B cells, our B cells are generated in the bone marrow, and these immature B cells express IgM receptors, which have low affinity, are supposed to have low affinity for self, or certainly not high affinity. If they have high affinity for self, then what happens is that these immature B cells start cross-linking their surface immunoglobulin, and that leads to their negative selection and deletion. So that the B cells that finally arrive in the periphery, ready to sense antigen or respond to foreign pathogens and so forth, are B cells that are really not designed, have little or no reactivity with self, at least at the level of IgM. Remember, B cells, and I'm going to talk more about this, have the ability to rearrange their immunoglobulin genes so they can go from a low affinity state or no reactivity to high reactivity if it's possible. And so they have what we would call an enormous ability to generate diversity or respond. Finally, if they do see antigen or foreign antigen in the context of in the periphery, and they get the right T cell help by the T follicular helper cell, as Dr. Calabrese alluded to, you get differentiation into a memory B cell and a plasma cell. And those plasma cells hone to the bone marrow where they live happily forever. So for vaccinia, for those of you who are old enough to be vaccinated for smallpox, you have plasma cells that are specific for smallpox, producing anti-vaccinia antibodies in your bloodstream, though it's probably been 50 years since you've been immunized. So probably the longest lived immune system, part of the immune system in our body. The B cell response, as we're generating our B cells have, as they come out of the bone marrow, have two options. If they are highly reactive, they're deleted, and that shows negative selection is present. If they have absolutely no reactivity, then there's probably not going to provide you with much help. But what I want to remind you is that B cell receptor affinity for specific antigen can change over time because of the ability to rearrange the DNA. Now, the T cell is really where the T cell education of the thymus always focuses on CD4 positive T cells, but it's exactly the same for CD8s. And I'm just going to remind you that what's relevant to the case that I told you about today is my 41-year-old bone marrow transplant didn't have a thymus when he underwent his bone marrow transplant. His thymus was long gone. It involutes at puberty. But while our immune system is evolving in the first few years of life, or even prior to birth, We have T cells, precursors, that are rearranging their immunoglobulin genes and then targeting going to the thymus. Thymus is also known as your neck sweetbreads. If you like your veal, and you can always ask your butcher for some neck sweetbreads if you want to have some thymus, but I really don't like it. Has anybody had neck sweetbreads? Yeah, you like it? Okay, so what happens in the thymus is that your repertoire, your education of your T cells occur. And what that specifically means is that, and I'll show this on subsequent slides, is that there's positive and negative selection. What does positive and negative selection mean? Positive selection means that your immune system, your T cell receptor repertoire, has rearranged their T cell receptor genes so that they can see antigen in the context of your MHC, your HLA class 1, HLA A, B, or C, and those would be your CD8 positive T cells, or HLA-DR, which DP or DQ, which would be your CD4 positive T cells. And actually, it's a very dynamic interaction. So if you make a T cell receptor that reacts with peptide in the context of HLA-A, then that T cell receptor, that T cell differentiates to becoming a CD8 positive T cell. And I'm going to show this on the next slide. Here's your thymus. The thymus is, many are called, but few are chosen. These are all these what we call double positive thymocytes that percolate through and go through a very high level of stringency and organization as they move through the thymus. And the process goes something like this. You first start rearranging your T cell receptor genes. And at that time, you're neither CD4 positive nor CD4 negative. You're neither CD8 positive nor CD8 negative. You have nothing on your cell surface. But eventually, you become a double positive cell in which you express CD4 and CD8 along with your T cell receptor. If your T cell receptor engages class 1 by just random arrangement, HLA A, B, or C, then you're destined to become a CD8 positive T cell. If it reacts with HLA-DR, DP, or DQ, then you're destined to become a CD4 positive T cell. Now, the other thing that's going on at this time is that you don't want T cells that react too strongly with self. Because you want them to react with peptide. So positive selection determines whether they go to a CD4 or CD8 lineage. If your T cell receptor, here after you've generated a CD4 positive or CD8 negative, if it reacts with self-peptides, that is peptides in the context of the thymus, then guess what? Then you've developed an autoreactive T cell. You don't want a T cell that reacts with self-peptides. In contrast to the periphery. So the thymus is like a particular schoolroom where the rules are different than in the periphery, because you want a mature thymus, a mature T cell, to leave the schoolroom and know it's okay to fight on the playground, but it's not okay to fight on the street. If you fight on the playground, if you fight in the classroom, you are not destined for survival, and you're deleted. However, after you leave the school, you're allowed to get in fights all you want. So the idea is that your T cell repertoire occurs that you have negative selection because you don't want T cell receptors that are not too cold, not too hot. You want them just right. If they're too strong, then you get negative. You can have autoimmunity, so you get rid of them in the thymus. If they're too weak, meaning they have no ability to see class 2 or no ability to see class 1, HLA-A, HLA-B, HLA-DR, DPQ, then you have what happened in my patient that I told you about. They're functionally immunodeficient. So they have CD8 positive T cells they got from a donor, right? Because he's getting he's got a bone marrow transplant, but all the herpes virus, all those zoster antigens are being presented in the context of HLA class 1 that is from him, his host. So in effect, he's a chronic immunodeficient state. I hope that's clear. So this patient, once you stop his acyclovir, he comes back because all his antiherpetic responses are from a host that sees herpes viral antigens in the context of an HLA that's not present in that patient. Okay. So there's problems with central tolerance. What are the problems? One, the thymus is not any larger than the size of my hand or my fist, probably much smaller. So how do you get all the antigens in the body into the thymus so that you can select against them, that you can delete the autoreactive T cells or see those peptides from all those antigens? And the answer is you can't. But the evolution has ground extremely finely and made certain decisions about dealing with this. So one of the things it's got to deal with is insulin, because if you don't have insulin, your child's not going to live to 14 or 15 and pass along the gene pool. I don't know if that's the same is true about prostate-specific antigen, but you can imagine that that would be an issue. You also we also have allergies, and so what's going on with this? How come these are foreign antigens? And we're going to talk about B-cell and somatic mutation in a second. So the layers of there have to be multiple layers of tolerance besides central tolerance. Central tolerance is where you get rid of the autoreactive T cell receptors, and that occurs probably mostly in the thymus. And then we have peripheral tolerance or peripheral anergy, where if a T cell gets stimulated in the absence of the right co-stimulatory signals, it's energized, it sort of goes to sleep. We also have active regulatory cells, which I'm going to present a case of in a second, Tregs, which actually suppress immune autoreactivity. And we also have to deal with the problem of apoptotic cells. How do you get rid of apoptotic cells so you don't have an autoimmune disease? So Len talked about this one, that there's rare monogenic risk. That gives you insight to pathogenesis. And we're going to use those cases to talk about this. But of course, most of the diseases that we're talking about, like rheumatoid arthritis and lupus, probably involve the synthesis of 40 or 50 genes. Okay, so the layers of tolerance in terms of monogenic problems are best summarized by these four, and I'm going to walk you through them. So we're going to talk about AIRE first, okay? And AIRE leads into a deficit of central tolerance. Now, how does that happen? Well, remember, what you need to delete a self-antigen is in the thymus. So if a T cell doesn't see the antigen in the thymus, it can then escape into the periphery and attack antigen in the context of the right MHC. So for example, our anti-insulin T cells, or T cells are specific for insulin peptides. So evolution made a decision. Evolution made a decision that we've got a big problem because we have places like the eye, we have places like the eye, and we have places like the ovaries where the antigens don't get out. They're never exposed, never going to get into the thymus. So they're sort of immunosequestered. They're sort of hidden from the immune system because they're sequestered. But what also happens is that you also have to make a decision that there's other parts in the body where these antigens might get out, and so you have to get rid of T cells that might react with them. Okay? So what you do is that you develop a system to express antigens in the thymus that are from other places, like the Isles of Langerhans, where you really don't care. There's no functional role of those antigens being produced in the thymus, except to act as targets for the immune system so that you will delete autoreactive T cells. And the gene that does this and seems to regulate this and transcribe insulin and other proteins in the thymus is called the AIRE gene. And it makes the AIRE protein, and it tells the thymic medullary cells, these are non-T cells, to start making all kinds of different proteins, and expresses them in the context of class 2 on their cell surface, or class 1. And what happens is that those T cells now see those peptides on medullary thymic cells, and they're deleted. Now they're tissue specific, meaning they're not doing anything in the thymus except as acting as a filtration mechanism to get rid of the autoreactive T cells. This is pretty slick stuff. So how can that, I mean, when you think about this, how did evolution select for this? I can't fathom what mutational event occurred. I mean, if there's ever an argument for intelligent design, this is almost it. But it's so peculiar, but it's so amazing, because what happens if you have a genetic mutation in AIRE? So you have to miss 2 copies, so it's a recessive allele. But if you happen to have somebody who has no copies of the AIRE gene, or no functional copies of the AIRE gene, they make no AIRE protein. What happens is that now they don't make those self-proteins, and you get autoreactivity. So let's take a look at what this works. AIRE messenger RNA is expressed in a few places, like the ovary, interesting, the spleen, the lymph node, but look at its expression in the thymus, huge levels in the thymus. And what's interesting is that if you take RNA out of a thymus, and you say from a mouse that has AIRE or a mouse that doesn't have AIRE, and that's in blue, is without AIRE, and you look for insulin messenger RNA, there's normal levels of there's insulin messenger RNA in the thymus if you have AIRE, but there's no insulin messenger RNA if you don't have AIRE. So what happens is that if you don't have AIRE, you're going to make T cells reactive for insulin, and guess what? You're going to get diabetes. Okay? You're going to get a lot of things because now what you're doing is you're making antibodies against, you're going to make an immune response, a T cell dependent response against proteins that are all over the body but in sequestered places because they're not normally in the thymus, and they're ectopic. It's almost like an ectopic thing. Their ectopic expression in the thymus to promote negative selection is not occurring. So let's give you a case. So this is a 18-month-old, develops very dry skin, sluggish movement. He's found to be hypothyroid, 1. Okay? At 6 years, he has alopecia. At 8, he gets candida. And at the time of puberty, he gets darkly pigmented and found to have an elevated ACTH, so he's got Cushing's disease. And then at age 18, he has idiopathic thrombocytopenic purpura. So this is all, so you can say he's got an immune response that's going against his thyroid, he's got an immune response against his hair follicles, he's got deficiencies in reacting with candida. Well, that doesn't fit, he's got an overactive immune response, right? Well, but now he's not able to fight candida. He's got Cushing's disease, so he's got adrenal failure, and he's got OITP. So he's got 5 different autoimmune diseases going on in him. Some are very organ specific. So this is a picture of somebody with AIRE, and they took their serum and they layered it on some ovaries. And what I want you to say is normally the ovaries are a very immunoprivileged site. You do not make antibodies against your ovaries. But here's a very strong autoreactivity with the ovarian follicles. So when this occurs in a woman, she's also going to have ovarian failure, right? Because why? Because antigens from the ovary are also expressed in the thymus. Remember, ectopically expressed in the thymus under this and to select to allow the ovary to remain as an immunoprivileged site that is not to be a target for autoimmunity. Now, the fascinating thing is, why do they get candida? And the thing is so fascinating, and it gets back to what Dr. Calabrese talked about with anti-gamma interferon antibodies and mycobacteria infection. What they do is they make anti-IL-17 antibodies. And this is the nail disease they get. And so when you think about, remember I was talking about central tolerance not being perfect? Well, if there was anything you would have selected T cells, if there's any protein in the body you would have expected to select T cells that would not react with a particular protein, it would be a protein made by T cells, right? So when we have those mycobacteria patients who've made antibodies against their gamma interferon, they must have a T cell that's specific for some gamma interferon peptide. And the exact same thing occurs in the AIRE syndrome. So this either tells you that IL-17 is not normally expressed in the thymus and is only expressed under conditions of AIRE, or alternatively, the immune response is so dysfunctional that it can now target cytokines. It's really quite extraordinary. So in other words, central tolerance is not perfect. In fact, because if you can make autoantibodies, that require T cell help against cytokines, which you would have expected to have been made in the thymus, it tells you that it's not working perfectly all the time. In fact, in most of us, there must be another mechanism by which this works. And that another mechanism is peripheral tolerance. And one of the peripheral tolerance mechanisms I'm going to talk about next, because it's a nice monogenic example, is the role of regulatory T cells. Now, regulatory T cells break all the rules. So they're the example, they're the exception that proves the rule. And what they do is that regulatory T cells are T cells that really react strongly with self. But for some reason, you don't get rid of them. In fact, what happens, they really react strongly with self, and they decide not to be, but they decide to be the sheriffs who can recognize self and say, you're from our town, you're not from out of town, okay? And what happens is they leave the thymus early. They get out of the thymus early and they go populate the body. So by the time the T cells start leaving the thymus, the sheriffs are already in place to monitor, to make sure that peripheral tolerance works. Now, what do? Well, here it is. Here's a T regulatory cell in purple, and it reacts very strongly with self-peptides. And what happens is that when it does, and it is engaging with self-peptides, and now you have a misbehaving T cell that decides to react with some peptide on that cell, or presented by that antigen, that regulatory cell turns it off, either by direct contact with the effector cell, or direct contact with the antigen-presenting cell, or by the production of cytokines, which are very good at stopping T cell growth and differentiation. And an example of this is that if you take some T cells and you put them into culture without any T effector cells, and they're specific for a particular antigen, and you throw in the antigen, the T cells proliferate, great. If you start titrating in suppressor cells or T regulatory cells, all of a sudden you see the proliferation getting suppressed. And this is what T reg cells do, and they're doing them all the time in all of our body. And what's fascinating is when they aren't there. This is regulated by a protein. This development of these T regulatory cells is regulated by a protein called FOXP3. It's another transcription factor, just like AIRE. And what it does in its absence is that you get a variety of diseases. You get autoimmunity, you get allergy, you get infection, you get tumor immunity, and you lose organ transplantation. So here's an example of somebody who's got a deficiency in the gene that encodes FOXP3. In other words, they have no T regulatory cells. Billy is born at full term. He develops atopic dermatitis. At 4 months of age, he develops intractable watery diarrhea. And then at 6 months, he develops type 1 diabetes. So we got skin disease, we've got bowel disease or intestinal disease, we've got diabetes. He's got diffuse eczema. He's probably got autoimmunity against hair. He's got diffuse adenopathy in his genes, in his lymph nodes. He's got splenomegaly. He's got 15% eosinophils. His IgE is sky high. Everything is going. He's got antibodies against GAD. That's the autoantibody, the autoantigen in diabetes. And he's got he's got basically the world's worst celiac disease. Here's Billy. He's got the world's worst celiac disease, and you can see this is an intensely inflamed lamina propria with all these cells in here that should not even be anywhere around. So what's interesting is that in the absence of T regulatory cells, everything is basically all systems are potentially impaired or can be targeted. And what that also sort of infers, as you think about all these different organ systems, is that the T regulatory cells are protecting against all of these things at all times. And so this obviously led into some of the excitement about trying to develop T regulatory cells to control disease, and we're still working very hard on this, but I don't think there's been any advances in that right now. I think most of the advances have been at the level of co-stimulation. The third we're going to talk about is getting rid of autoreactive T cells that happen to survive, that don't get deleted. And what we're going to talk about is FAS and FAS ligand. And remember, as we die, we're constantly reshaping our body and so forth, and we're having cells undergoing apoptosis. Here's a nice normal cell. It starts dying, undergoing apoptosis. Notice the nucleus, the DNA starts condensing, starts moving out to the cell surface, and you dump all the DNA out in a nice bleb on the surface for some other cell to come on and pick it off. If you don't, FAS ligand is designed to engage FAS on T cells at the end of a immune response. So One of the things Dr. Calabrese was talking about was T-cell exhaustion. And T-cell exhaustion occurs when when the process doesn't sort of grind to its usual halt. So what happens, you get exposed to antigen, your T-cells expand, the antigen is cleared, your T-cells start sort of fading away, but they don't necessarily die unless they're actively told to die. And the way they're actively told to die is via Fas ligand engaging Fas on the surface of the T-cell. And this also is true for B cells as well. So what happens if you don't have Fas ligand? Here's a story of a young woman. She, at 18 months, she had an enlarged spleen and extensive lymphadenopathy. In other words, once her T cells turned on, once her B cells turned on in response to just life, they weren't being eliminated when they were no longer needed. They were hanging around. The white count was elevated. Her IgG was sky high, as you can imagine, by having a hyperexuberant immune system. Her IgA was elevated. IgM, her B cells were very interesting. Her B cells were normal, but what was interesting is that her T cells were surviving, and they were double negative. They had neither CD4 nor CD8, because what's happening is that the immune system is trying to compensate for the inability to eliminate these B cells, these T cells, and what happens is that they're surviving. And what's also happening is that these T cells are not getting the double negative T cells that started in the thymus that were supposed to be deleted are not being deleted. So at this point, the only thing you can really do is try to treat with immunosuppressive medications, and then at age 32, she develops an autoimmune neutropenia. In other words, if you can't get rid of your cells that you're supposed to normally get rid of, they're going to be either maintained, either as, and when I say get rid of, I mean either in the periphery or in the thymus. And what happens is that your T cells persist. And here you can see the lymphadenopathy here that's really quite remarkable. And you can also see from a posterior end here. And the final thing is the role of clearance of apoptotic cell bodies, which we'll talk a little bit more about when we talk about complement, because this does involve a story about complement. And what I want to remind you about is that the proximal pathway of complement, one of its major roles is to clear apoptotic cells. We'll talk more about that in a second. And you need C1, C4, and C2. But C1q is the one that's a big winner. And we all recognize this from its association with lupus. And the reason why it's probably associated with lupus is shown on the following slide. Is here we have central tolerance. We have B cells that we've eliminated those autoreactive B cells. But B cells come into the periphery, and maybe they have a surface immunoglobulin that has some reactivity with some self-protein like Rho or Law or Smith or RNP. But what happens is that when a B cell engages this, the other fascinating thing is that that B cell also has danger signals like toll-like receptors, which are engaged by, guess what? RNA, DNA, Rho, Law. And what happens is that this sends a two-fisted signal to a B cell. You not only cross-link the B cell receptor for its specificity, but the proteins on the surface of the apoptotic cell activate that B cell and to undergo proliferation and go to a lymph node. And this eventually leads to eventual activation and the breaking of tolerance, affinity, class switching, and Dr. Silverman can address this in his talk on T follicular cells. But what I really want to emphasize is that the reason why this doesn't happen in most of us is because we're very good at clearing these apoptotic cells before they can ever engage a B cell. Remember the apoptotic cells, like when a woman has been lactating and stops lactating, all the breast size changes in size, and all those cells that are in there, all those breast cells have to undergo apoptosis and get cleared out. Well, the same thing is that's not happening in the immune system. That's happening in the tissues. And what you don't, but if you got those apoptotic cells into the lymph node with a dendritic cell or something, or a T cell, then you could imagine autoimmunity developing. So one of the most important things is clearing these apoptotic cells in the periphery, and C1q, C4, and C2 do this. So in the absence of C1q in particular, there's a profound risk for a profound accumulation of apoptotic cells. So how does that manifest itself? Well, I think you can all recognize, you've all probably seen C4 and C2 deficient patients in your clinic, but here's a story of a C1q deficient woman, young woman, 4-year-old who presents with fever, facial edema, joint pain, and oral ulceration. She was diagnosed with DLE, discoid lupus, and the fascinating thing was that her C3 and C4 were within normal range, but her CH50 was undetectable, okay? And then her ANA and rheumatoid factor were positive. She was identified as having C1q deficiency, and she did not really, and she partially responded. But what was fascinating is you gave her FFP, her CH50 recovered to within the normal range and then became undetectable 24 hours later. So you could give her some FFP, and she would, if you could give her FFP once a week, you could kind of keep the apoptotic cell clearance going and keep it from building up and triggering this immune response. And shown here is her hemolytic activity. Here's normal human serum. Her patient serum had no hemolytic activity, but if you actually measured C1q activity of 7% of what normal was, her C4 and C2 are normal, pointing to the absolutely central role of C1q as the first arbiter of getting a apoptotic cell cleared. And that nice sort of lunar module that Dr. Calabrese showed made that point, I think. Okay, so I finished what I'm going to cover. I think we've got ourselves titrated well for lunch, and now we're in the last phase. And so here you go. We have our audience response system going here. So which of the following represents failures of central tolerance? Oh, that's great. Okay, that's great. And I hope you all think about the fact that these patients make anti-IL-17 antibodies, and that's probably what causes their candidiasis. Again, making the point like Dr. Calabrese did about the CARD9 mutation in Th17s. But has anybody seen a lot of candidiasis has anybody done clinical trials with anti-IL-17 antibodies? Yeah. And have you seen any candidiasis? No, it's amazing. But it's absolutely unambiguous that if you're born with this disease, I think it's like 91, 95% of the patients have that chronic mucocutaneous candidiasis. Okay, good. Which of the following represents failure of peripheral tolerance? Okay, perfect. Actually, in some ways, lepromatous leprosy is not too far off from there, but that's a correct answer. Good. Food allergy and allergic asthma, probably other examples, so those are also correct. Match the following. This is not an audience response, just because it's hard to do this, but this is the way. I didn't design this slide. I think it might be easier just sort of put them straight across, but anyhow. Thank you so much, and here are the conclusions, but I think you know most of them. And what I'd like you to just think about is what these monogenic alleles are going to tell us, and these deficiencies are going to tell us with our own patients as we treat them with more and more immunosuppressive therapy. Thank you very much, and I'll take any questions.